Good afternoon. This is Dave Wilkin, Chief Operating Officer of the Occupational Health Clinics for Ontario Workers. Welcome to our webinar today on using scientific evidence to drive prevention and compensation. Our first speaker will be Dr. Paul Demers, Director of the Occupational Cancer Research Center, who is also a senior scientist with Cancer Care Ontario and a professor at the University of Toronto Dalla Lana School of Public Health with a background in industrial hygiene and epidemiology. He's going to be reporting on a report that he's done at the request of the Minister of Labor from the previous government, now received by the current government, the Ministry of Labor, Training and Skills Development. And then we're going to have two other panelists, Catherine Lapel, Professor of Law at the University of Ottawa, and Bob DiMatteo, a labor activist. I'll give some more in-depth introductions of them when they speak. And right now I will turn it over to Paul. We will be putting a link to his report to the Ministry of Labor into the chat on both the WebEx webinar and the Facebook live stream. Thanks very much. Paul?
Okay, thanks, Dave, and thanks everybody for coming here today. Although I'll take responsibility for this report, and if you don't like anything in it, you should blame me, but in preparing this report, I had a lot of help from Anya Keith from Vancouver, who is, I believe, attending here today, and Sarah McCormick Rhodes, who actually now lives here in Toronto. They both assisted me with the report. Anyway, as Dave said, this report that I'm going to talk about today was requested by the Ontario Ministry of Labor, now the Ontario Ministry of Labor, Training and Skills Development. It was initially requested by the previous government, but then which then very shortly ended up falling to another government, which renewed that request in January in 2019, which was about 2 years ago, and I completed it a year ago. It had three basic questions. How can scientific evidence best be used in determining work-relatedness of an occupational cancer claim, particularly in cases when there are multiple exposures? Are there any best practices in other jurisdictions that Ontario should consider adopting, and what scientific principles should inform the development of the compensation of occupational disease policy? Now, just to kind of get us started, I just wanted to say that there are a lot of things that cause cancer in the workplace. The agency that is probably the most widely recognized internationally for the classification of what causes cancer is the International Agency for Research on Cancer. And over the past decades, they've evaluated about over 1,000 different things that could potentially cause cancer, which they then group into group 1, which are known, are established causes of cancer, group 2A, which is probable, group 2B, which is possible, and group 3, which they need more evidence for. And in all cases, what you see here is that the majority of the things that they've evaluated are actually occupational, whether that's based upon the types of studies of what causes cancer that they're looked at, which I have here in orange, which is based upon epidemiology, or whether that's simply that the people who are exposed to that particular carcinogen are exposed in the workplace. So there are a lot of things out there that do cause cancer. As an example, and IARC makes their evaluations now specific to types of cancer. So it's not all cancer. There are lung carcinogens, and there are things that cause bladder cancer and other things like that. These are some of the major occupational lung carcinogens that either fell into that group 1, which is very well established, And I bolded the ones that I think are important in the province of Ontario, but also are probably particularly important across Canada and many other industrialized countries. And then there's also, of course, a number of other things that are probable where we still would like to have more evidence, but at least there is quite a bit of evidence supporting that they could be carcinogenic to the lungs. But when you look at those many occupational lung carcinogens, an important thing to recognize is that they can impact a very wide variety of different groups in society. I think we often think mostly of just jobs in manufacturing or mining or construction, but in fact it can hit a lot of different groups. And so you see here some healthcare workers or people in the service industry, people in agriculture. Another thing, though, if you look at this picture, is that most of the people here actually are potentially exposed to more than one carcinogen at work. And oftentimes, that might be more than one thing that might even impact the same type of cancer. And that's very important and something to kind of remember as I go through this review today. In terms of compensation of cancer in Ontario, there's a couple of principles that are kind of built in to our legislation that governs compensation or the policies that are there. Three general principles that I wanted to kind of remind people of. One is that employment doesn't have to be the only or the predominant cause. It just has to be an important contributor to something causing cancer. We don't have to have absolute certainty, and the worker is supposed to be afforded the benefit of the doubt when it comes to compensation. So these are principles that are actually part of our compensation system. Now, many compensation systems that are similar to ours around the world use what we call presumptive lists, or deemed lists is also sometimes what they're called. They're basically a list of exposures and potential cancers that are basically where there's a lot of evidence, and that they're basically stuff that is put into place to make it easier to submit a claim that meet those kind of criteria that involve that exposure and that disease outcome. Ontario has probably the shortest list that I've actually seen among those, and they fall in the legislation into, or in the I believe we call it legislation, into Schedule 3 and Schedule 4. One is rebuttable and one is non-rebuttable. So non-rebuttable is particularly a strong area to be in. And what you see there is mesothelioma and asbestos, and nasal cancer, and employment at two specific facilities where there was exposure to nickel. In the rebuttable category, we see skin cancer and a number of different types of causes of skin cancer, as well as nasal cancer more broadly in the nickel industry. And that's it. So I'll be coming back to that, but those are the things that are on those presumptive lists here in Ontario. Now, over the past 10 years, when I prepared the report, that I had data. This is what the numbers of cancer claims were accepted in each year. And so it allows you to kind of see what things look like over time. It changes in a mix. It's not, although there is perhaps a slowly decreasing number of mesotheliomas, you see towards the end there that other cancers are, their compensation is on the rise, and things jump around a bit. But overall, what we're getting in Ontario is approximately 170 accepted claims per year is the average over that 10-year period. And this excludes firefighter presumptive claims. Now, when I gave you those presumptions, it didn't include firefighters, which over the last probably, I think, decade or so, a number of different presumptions very specific to firefighting have been added. And firefighters are an unusual case, and I've kind of excluded them because they are such a special case from this report. So the statistics I'm going to give you are for non-firefighters. So what is important to know that is on average there have been about 400 claims filed each year over those 10 years. And of those submitted claims, 170 are accepted, which is around 40%, again, excluding the firefighters. 45% of those accepted claims are for mesothelioma, 36% are for lung cancer, and then smaller percentages are for things like skin and bladder and other types of cancer. Now, perhaps not a surprise when you see all those mesotheliomas, over half of all claims were for cancer due to asbestos. And the acceptance rate for those was a little over 60%. So claims that are filed for asbestos, particularly for mesothelioma and lung cancer, have a very high acceptance rate. And other claims have a lower acceptance rate, around 19%. So that's just to give you a little bit of a quick view of Ontario. Well, just how many cancers are there that are work-related here in Ontario, I guess would be the question that would arise from that. So you see that there were 400 submitted. We actually did a report, the Occupational Cancer Research Center, in collaboration with researchers across the country who are working in the area of occupational cancer to try to estimate the number of cancers nationally, but we also produced an Ontario report. And it's available online through our Occupational Cancer Research Center's website. These were the top work-related cancers that we cover in the report. Now, the report really is limited to cancers and carcinogens where there is a lot of evidence. So there are those things that you see that were in Group 1 by the International Agency for Research on Cancer. Overall, here you see the number of cancers that would be expected in Ontario annually based upon what we know about historic exposure patterns, because cancer takes a long time to develop. And you see at the top of the list, sun, outdoor work is associated with a lot of non-melanoma skin cancers. Asbestos, no surprise, is a big hitter. Diesel engine exhaust, crystalline silica, welding fumes, nickel, chromium, environmental tobacco smoke or secondhand smoke. That's what ETS is, radon, and the list goes on. Certainly you see that lung is the most frequently mentioned here, but you also see skin and mesothelioma and some other cancers as well. Now, at the bottom, you'll notice some things in parentheses, and those are ones that were in that second group at IARC where they're probable human carcinogens, and that includes things like shift work and some of the polycyclic aromatic hydrocarbons. These are the kind of soot and black smoke and things like that that arise when you burn things. So if you look at our report and how many cancers you would have expected over that 10-year period versus how many were compensated, this is what you see when you line them up side by side. So what you see is the top one that was compensated here in Ontario, and it was probably about 130 out of that 170 each year were asbestos-related cancers that were compensated. And then you see the expected numbers there. So the most cancers there are compensated there, but there are a much larger number that were expected, primarily lung cancers. You can see that we have some compensated ones due to defoliants and herbicides, which were not part of our report. Crystalline silica, benzene, outdoor work, and other things there. So there's a very big gap between what we believe is out there in occupational cancer, that is, cancers caused by exposures at work, and the number that are actually compensated. Now, you might wonder how we compare to other provinces, and we have limited access to data from other provinces, but we do have information on fatal claims that is available publicly to the Association of Workers' Compensation Boards of Canada, the AWCBC. And so we looked at a year, one of the more recent years that was available, 2015, where there were 161 fatal cancer claims accepted based upon AWCBC's database. And that gives us 3.1 claims per 100,000 workers covered. So we're trying to compare across jurisdictions. We have to think about the size of the province and how many workers are being covered by their systems. The overall rate for the entire country was 2.5. So Ontario compensated more fatal cancers than the average for Canada. British Columbia, Quebec, and Manitoba were very close to that national average. Newfoundland and Labrador had the highest rate at 5.2, which maybe was a bit of a surprise to me. Alberta had the lowest at 1.2. When you look across all of Canada, in fact, mesothelioma was 46% of all fatal claims in Canada. So very similar to what we see for Ontario. And very similar to Alberta. For Quebec, a higher percentage of those were, of their accepted claims were mesotheliomas, and BC, almost 2/3 of their claims were mesotheliomas. If we want to compare to Europe, this is their accepted claims rate. So these aren't just fatal cancers, these are all cancer claims accepted per 100,000 insured workers. And I'm not giving all of the countries here. This is from a report that looked at 9 different European countries. And I have Ontario here for reference. So in 2016, Ontario was 2.9 per 100,000. Germany was the highest, approximately 5 times the number. France was the second highest, and so on. So you can see here that some European countries compensate a lot more cancers than Canada. Canada is fairly similar, I believe, to the United States in many ways, and some points might be better. And Ontario ranks well within Canada. So if we look at Ontario compared to Europe, we accepted 42% of submitted claims in 2018, which was the year that they had in the report. The highest acceptance rates were in Austria and France, which were much higher than that. The lowest was in Denmark, where it was actually quite a bit lower than ours. Something that's important to recognize that both Germany and France use these presumptive lists. This is what I was talking about earlier, things where it says, okay, asbestos causes these cancers, work outdoors causes this, skin cancer, diesel engine exhaust causes lung cancer, and so on. And in fact, Germany and France, who were the top compensators, if we want to call them that, actually almost only went off of their lists, and so Germany was the highest number, 5 times higher than Ontario, and they only accepted 28 off-list cancers in that year that we're using for comparison. France did a little bit more, and this is just a very tiny percentage of what they actually accepted. Now, In that year, Ontario had 77% of all their claims were asbestos related in that particular year. But 75% or more of all claims were asbestos related in all of the countries in Europe that were in that report, except for Germany. So we're not so different from Europe in that way. France was the only country to compensate more asbestos-related lung cancers than mesotheliomas. All the other countries compensated many more mesotheliomas than they did lung cancers. And I say that because, in fact, asbestos causes a lot more lung cancer than it does mesotheliomas. So you would expect that relationship to be different. And another thing that I thought I would add here is that in 2015, Germany added skin cancer caused by UV radiation to its list. So it was only in 2015. And in 2016, 58% of their accepted claims were for skin cancer. Now, why is that important? One is it means that they've got a list and people are very aware of it. So they just add something to that list. The word gets out and claims are filed for it and they're accepted. So it's a very functional system there, but people are very aware of that presumptive list. Now, there are challenges for workers' compensation that I think we face in all jurisdictions that are really in common. And one is that big gap that we see between the number of occupational cancers that we believe are out there and the number that are compensated is mostly due to claims not being filed. It's not, even though the majority of claims overall are not accepted, the big piece of that gap is that claims are not actually even filed in the first place. And there are some challenges for that. A lot of physicians don't take a good occupational history. You can't really tell when you diagnose a cancer what caused it. Those exposures occurred long ago. And cancers have multiple causes, and so you get situations in which there's an assumption, for instance, that a cancer is just caused by cigarette smoking, whereas that may not be the case. There are other factors that can contribute to that. An important challenge is that information on historical exposures is often lacking. I mean, we often don't have information about who was exposed in the past, and that's a very important gap that we need to fill. Now, the topic of today, and I'm talking mostly about my report here. I'm hoping that we get more to the topic of today when we have a panel discussion later on, but that, clusters, kind of large, complex workplaces like the General Electric Peterborough plant and new hazards all require us to have really adequate resources to investigate them, and probably systematic approaches to make that, to kind of help us get through that and actually identify compensable cases. Another thing that I wanted to raise is that a lot of our evidence on what causes cancer comes from epidemiologic studies. And those epidemiologic studies are really designed to look at the risk of cancer in groups of people, not in individuals. Individuals are tougher than groups of people. In groups of people, we can see large patterns, and that's what we do when we're doing those kind of studies. But there are challenges then with trying to use that evidence to actually look at individual cases. Now, part of the report, and it's a long report, I'm not covering all of it in the time that I have today, was to look at other jurisdictions. You see some of the comparisons that we made in the report, and we did try to look at what we thought were some of the better practices. Certainly, a number of countries that do compensation and compensate more cases are using presumptive lists. And so they're actually using those pretty effectively. And one reason that's important is that it can really speed up compensation when you've got a presumption in there like that. And it also frees up resources, which can be limited. So there can be more time spent on other cases and trying to figure out other cases. So that has worked very well for some jurisdictions. There are some interesting targeted compensation programs. The U.S. Department of Energy and the World Trade Center program that we looked at. These are ones where there is a lot of resources that are being spent. Maybe it's tougher to do that when you're doing it for, let's say, an entire province, or in the case of the United States, an entire state. But they also knew more information about and collected more information about potential exposure. They're very specialized programs, but they're quite interesting to look at. A number of programs actually have special or scientific advisory panels, and they use those effectively to provide advice on compensation and to make some of the decisions kind of independent of the individual adjudication process. And many of the more effective compensation organizations had either internal or what we call partnered scientific capacity. That is, the state of Washington has their own kind of research institute that works with both their compensation system and their equivalent of a Ministry of Labor, so on prevention and compensation. Germany has a compensation research center that actually helps them a lot with compensation issues. Other places have more of a partnered situation where there's an independent center that actually helps provide that kind of support. Now, I'm not spending a lot of time here today on a lot of the scientific evidence that was covered in the report. So I'm just going to give you a bit of a high-level summary. Starting about 65 years ago, we began to understand better how cancers are actually caused. And it started with developing models and theories, and that's been supported now with a lot more experimental evidence and other things, other types of human evidence, as well as evidence from animals and looking at cells. And that kind of evidence has come, I think, pretty clearly to show that almost all cancers have what we call multiple causes. And when I say that, it may sound a bit odd to you. We're used to thinking, oh, well, this cancer was caused by smoking, that cancer was caused by asbestos. And that's actually, it's not really always that simple. And it's usually not that simple. I think many of us might have older relatives or friends who smoked a lot, and some of them got cancer and some of them didn't. Why is that? We call it chance, but in fact, I'm not just a believer that things are just chance. They're just things that we don't simply have a way to measure. And one of those things is that those individuals might have other exposures in their past. They might have different genetic things going on. There's a number of different things, but most cancers have multiple causes, and that's important in compensation. So it's not, as you remembered in principle, that something has to be the primary or the most important cause. It just has to be an important cause of the cancer. The other thing to remember is that different causes take different lengths of time to operate. We have different causes, they're operating at different times. So it's very important to know what people's history is of exposure. Now, these multiple causes can work together in different ways. They can be independent, that is, the increased risk that you get from two different causes may add together. They can be synergistic, that is, things like cigarette smoking and asbestos. When you add those two together, things are much worse than just the simple addition of those two things. In fact, a person moves into a very, very high risk category. And sometimes we even call that multiplicative, or you're multiplying the risk, you're not simply adding the risk. Occasionally things can be antagonistic, but they're less, and antagonistic means that you're exposed to two things that cause something and the effect is lower than simply adding them together. That's possible, it's less common. Now, the problem is we don't always know that. We don't always know what the impact is of these multiple exposures. Now, probably over 30 years ago, by my count, the American Conference of Governmental Industrial Hygienists, hardly a radical organization, although I will confess that I was a member of the TLV committee. I was actually the vice chair of it at one point, about 10 or 15 years ago, I guess. But in any case, they had a statement in there that when there are two or more hazardous substances that have the same effect on the same part of your body, so the same target organ or system. So let's say an example of that is you're exposed to two things that cause lung cancer. You add those things together, and what do you do about that? Well, in their case, what they're saying is that as a default, we should consider that they should be at least additive. That is, we add the effect of those two things together when they affect the same organ and the same person is being measured. This has been accepted in prevention as a principle for over 30 years, and I'm going to recommend that this is a principle that we should recommend in compensation as well. In the absence of anything else, if somebody is exposed to both diesel engine exhaust and crystalline silica, which is not uncommon for somebody in mining or in some areas of construction, we should think about that as at least adding together, and unless we have evidence that says that that's not the case. Some of the other things that we talked about in the report is that there are independent scientific assessments on causality that have been done by IARC, the International Agency for Research on Cancer that I talked about earlier, and some other organizations that could be used to help expand our list of presumptions. It's more work to do those presumptions, but in the end, they make and they facilitate compensation. Also, that because what's driving these things is evidence from epidemiologic studies, that we always have to have some flexibility in applying things like minimum lengths of exposure or latency criteria, is how long ago people had to be exposed. We always have to have at least some degree of flexibility there. The majority of cases might apply to meeting some minimum criteria, but there is going to still be a place for case by case looking at the special situations in particular claims. And the last thing I'm going to mention here is that really good exposure data is a very important part of making science-based decisions on causality. It really is an essential component. So the better the exposure data we have, the better decisions that we can make. And so I'm just going to do a little shout out to one of our speakers who's coming in a little after my presentation, and that would be, the report that the DiMatteos did on General Electric. I think was a very good contribution in that case. We need to document historical exposures. That has to be considered in looking at claims. So I'm going to move to the recommendations here. In the report, this is the first one here is that the WSIB needs to update and greatly expand its list of presumptions. You probably could have seen that coming from my presentation. And that needs to reflect our current state of scientific knowledge. The presumptions have not been modified in many years, and that has to be taken into consideration. For those of you, I realize I looked at the list of attendees. The WSIB is the Workers' Compensation Board of Ontario. So I'm sorry for folks who aren't from Ontario. Just I should explain that. And some of those presumptions you saw were based upon specific, locations, specific employers. And that's not very generalizable. In fact, it was nickel and nasal cancer, and not just nickel exposure to facilities. So that was another piece of this recommendation. And although I'll say that this relates to the WSIB, I've seen in looking through a lot of presumptive lists out there in different systems where they need updating. So also true. Oh, somebody needs to mute again, please. The WSIB also needs to update policies relevant to the of cancer claims. There's a lot of policies that are in need of updating, and we need also new policies that relate to multiple occupational carcinogens and the weighing of non-occupational carcinogens when looking at occupational carcinogens, where there is some policy out there, but I believe that those policies need to be looked at again, and just to make that system or that decision-making as transparent as possible. I've also recommended that the compensation system needs to create an independent scientific review panel to review and recommend changes to schedules and policies, and to look at scientific reports and assist in the selection of external consultants and researchers. And I've recommended that it be made up of independent scientists with a broad range of scientific expertise, and that the process should include stakeholder input on who the scientists are or the selection of scientists. This has been done in for some other purposes in other places, but that really it be a scientific review panel. And this is something that not everybody agrees with. Some review panels that have existed in the past in Ontario and elsewhere have really been more what I would call stakeholder. They've had, let's say, employer and union representatives. And I think that there's a role for that in providing and reviewing and providing advice and any decision-making in compensation. But I'm actually recommending a scientific panel in and of itself, which is would be independent. Now, in the past, the WSIB had internal scientific capacity, and over the years, that had really dwindled down to just a few people left. And so I was recommending that be rebuilt. That's actually starting to happen, I believe, with some addition of new scientists. But it needs to really be built up so that there is good enough internal scientific capacity to be able to handle the questions and to be keeping up to date with scientific evidence. And that needs to involve people from a number of different scientific fields. There need to be stronger partnerships with external research centers, and I'll confess that that's a bit self-serving, since people will have known that I'm with one of those centers, so I'll admit I have a conflict of interest there, and that we have to encourage the development of surveillance systems to support decision-making and adjudication, and to identify emerging issues, which we're also trying to be involved with. Provincial capacity is also needed to investigate cancer clusters and other emerging issues. And I've actually recommended that ideally, in my mind, that would be in the ministry, that it would not be within the WSIB. I think it's better to have that independent. Also, the ministry has the right of entry. They have a lot more powers in the workplace in terms of investigation than pretty much anybody else in the province. So I think that that's an important capacity. Historically, there was a capacity that was there, and that has been lost over time. So that's an important point, but maybe one that, again, not everybody may agree with. One of the things that got pointed out to us is that that the WSIB and the adjudication process faces a lot of barriers to getting exposure information, even from the ministry itself. That takes time, and that slows the compensation process. We recommended that those barriers be decreased in order to better allow exchange, and that that different sources of data should be explored, where there may be relevant exposure data, maybe not even just in Ontario. If we don't have the data in Ontario, we can look elsewhere. And so we specifically mentioned the Canadian Workplace Exposure Database. We also recommended that the ministry, and I think this may have, I'm not sure, but I'm guessing that this took the ministry by surprise. They were expecting we were just going to make recommendations to the compensation system, but we've made a few directed actually at the ministry. That they should be collecting copies of exposure monitoring results from employers at the time of inspections, and computerizing those to make that kind of data available, exposure data available. The ministry historically used to collect its own measurements, and those were available. They're no longer collecting that data, so it is not available now. But inspectors are supposed to be looking at it when they go in and do inspections. The federal inspectors actually do collect copies of that monitoring data. Those are entered as a PDF, Adobe Acrobat formatted thing that they actually enter into their electronic records on inspections. And so those are available and can be actually used to create an exposure database. So it's not that that can't be done. And again, another recommendation of the WSIB to work with external partners to digitize or put in a computer format historical exposure information, and perhaps even employment records for high-risk industries, again, to facilitate compensation. And this is my last recommendation, which is good because I think I've hit my 45-minute mark. And this was beyond the scope of this particular report. But again, I want to say that the biggest gap that we saw was the gap between, in terms of how many cancers, workplace cancers are out there, was not the gap in terms of submitted claims and accepted claims, but it was even the gap in between the number of submitted claims and the number of real workplace cancers that are out there. So we really need to improve medical education. One last thing I'm going to mention about recommendations is that many of the recommendations that I just presented are not unique to this report. In fact, you see similar ones in a number of different, coming from a number of different organizations that have made similar recommendations to the WSIB, and somewhat similar in other provinces as well. So this is, even though we've kind of put these together and maybe we had a little, perhaps a little harder tone in our recommendations, but still, these are not unique recommendations, and we've known about this problem with medical education for a long time. So it's one that continues to need to have more resources. So thank you for your attention. I've listed the core sponsors for our center, which is based in Ontario Health and supported both by the Ministry of Labour, Training and Skills Development, as well as the Canadian Cancer Society. And then I wanted to thank the staff of the Occupational Cancer Research Center, also for their assistance, including Kate Jardine and Wally Lewicki. So that's it for me. Thank you very much.
Thanks, Paul. That was a great, very clear presentation. So